Welcome back, everybody. David here again with Med School Boot Camp. So in this next video, we're going to talk about arguably the most important seronegative spondyloarthropathy in this entire chapter, and that is ankylosing spondylitis. And so ankylosing spondylitis is another one of our seronegative spondyloarthritis or a seronegative spondyloarthropathy. Remember, this means it is a chronic inflammatory condition that is negative for the rheumatoid factor. That's kind of what we say when we talk about a seronegative condition. And so if we look at the pathophysiology with this condition, we're going to notice some similarities between other conditions that are also seronegative spondyloarthritis. These are inflammatory conditions, right? It's an overactive immune response. This leads to increased inflammatory markers, including increased TGF-beta, TNF-alpha, interleukin-17, and even interleukin-23. These ultimately lead to increased T cell and macrophage recruitment. Remember, our interleukins are things that are going to draw in our T cell and macrophages. So we have interleukins that go to a certain area. They're going to release a bunch of molecules, sometimes called cytokines, that are going to then bring in more molecules. These can be our macrophages or our T cells to actually destroy the tissue and actually create that inflammatory response in the body itself. And so if you recall from immunology, we have a release of cytokines in the body that lead to more cells being recruited. And so that's the process that occurs here. We have an overabundance of these molecules, these cytokines, that are then prompting more cells, that can be our T cells and our macrophages, to come to the area. Sometimes this can be a good response, right? If we have an infection, we need the body to take care of itself, that's great. But too much of anything can be a bad thing. And here we see an overreaction or an overabundance of this reaction, which ultimately leads to joint erosion and spur formation. We have too much inflammation in areas that it doesn't need to be. This leads to infiltration of the soft tissue and bone with extra inflammatory markers, extra cells that then destroy the surrounding tissues. And so it's really important to be kind of familiar with this idea, right? This is just an overreaction of the body's immune response. Now, when we think about our presentation here, this is going to be more common in males compared to females, and typically in that 15 to 35-year-old range. Again, I talk about this a lot. Test-taking strategy here. Think about the most common age range that they would ask you about on a board question. There's certain pathologies you might be thinking about elderly patients, right? 60, 70, 80 years old. Certain pathologies we're thinking about younger patients, 6, 7, 8 years old. And then some pathologies like this where we're in the middle. We're kind of in that middle age range, that 15 to 35, where these pathologies are more common in these patients. That doesn't mean they only occur in this age range. But again, for test-taking purposes, what's the most common? What's the most likely presentation they would ask you about on test day? It's going to be this age range right here. Now, here's a super key point. I'm going to put a star by this actually. Question stems are often going to talk about symmetric bilateral low back pain, particularly in the sacroiliac joint. This is super important, right? Back pain in general is a very common presentation for patients, but usually we think about it in an older patient. We don't typically think about a 25-year-old having back pain unless it's an acute injury, a muscle pain. But if a patient is coming in with chronic bilateral back pain and they fit some of the descriptors, you want to inquire more about some of the history, what makes it better, what makes it worse, because you have to have this on your differential. You have to have ankylosing spondylitis as a possible thing that can be causing the patient's back pain. Now, in question stems, again, they want to give you classic presentations. So often they'll talk about how this improves with activity, but does not improve with rest. If we think about musculoskeletal pains, right? Let's say we pulled a muscle in our back. Typically, we expect this to get better with rest and worsen with activity. But here we see the opposite, and that's why this is super, super important. We see this improves with activity. So the patient goes on walks, the back pain gets better. When the patient wakes up in the morning, the back pain is worse, or when the patient's on the couch. Why? Because rest does not improve this patient's symptoms. Again, we can differentiate different etiologies. Are we thinking more muscular pain where these findings would be the opposite? Or could it be ankylosing spondylitis where we see these things right here? Again, this is not what we classically think of. Typically, we'd say, oh, if you rest, it should get better. But in these patients, that is not what they will be reporting. They will be reporting that rest makes the pain worse for them. Now, the question could also talk about the range of motion. As you would expect, we're going to have decreased spine mobility, right? And we're going to talk about why this is specifically when we talk about our diagnostics here in just a moment. Now, they might also talk about some other findings, right? These would be the classic ones that talk about the sacroiliac bilateral joint pain, but they can also talk about arthritis in other areas such as the knees, the ankles, the hips, anterior uveitis. Remember, we talked about that in the overview video, that a lot of these seronegative spondyloarthritis conditions are actually associated with some extra articular manifestations as well. And they often talk about the eye findings, particularly anterior uveitis for these conditions. These patients can also have restrictive lung disease, aortitis or aortic regurgitation, or enthesitis, which again is inflammation of the tendons or ligaments. So how can these patients have such a variety of physical exam findings? Well, it comes down to the fact, again, that we have an overabundance or an overreaction of inflammation in the body that ultimately destroys the tissues. This destruction of tissue often leads to decreased mobility in a variety of different places. So for instance, we talked about how the spine mobility can be decreased, right? If we have kind of stiffening or solidification of the sacroiliac joints, which can be due to an overabundance of inflammation and ultimately new bone being formed, this stiffening, this restriction in the body can cause a lot of these problems. So if we think about restrictive lung disease here, we say that the restrictive lung disease is due to costovertebral and costosternal ankylosis. So if I just do a really quick drawing here, we kind of have our sternum and our ribs. Remember, our ribs kind of attach to the sternum. with cartilage, right? We call this the costosternal junction, right? It's the costo for ribs, the root word, and then the sternum, the sternal area is kind of the junction, right? The costosternal junction. And on the backside, we also have the costovertebral junction. That's where the ribs connect to the area near the vertebral bodies, specifically the facets. Now, think about what happens if these areas continue to have a bunch of inflammation and destruction to the area, where we're going to have the joint erosion and bone spur formation that we talked about here, right? So these are going to become stiff. They're not going to be as mobile. The cartilage is going to become really rugged. And so now when they previously were able to tolerate a much larger shearing forces, it might not be able to go quite as far because of the stiffening of that joint, the stiffening of the cartilage in the joint, the junction, if you will. So if we think about how this might cause restrictive lung disease, if you will, for a minute, just imagine that my face is the sternum and my fingers are the ribs. If I can expand away from the sternum, right, the cartilage while I'm breathing, then that's great. But if I get really stiff and attached to the sternum, I can't expand much. That's how you get restrictive lung disease. When you try to take a big, deep breath, you can't expand quite as well. And that's what we see happening here. This inflammation leads to less ability for expansion to occur, more stiffening of these joints. And that's how you get the restrictive lung disease. And similar things here, we can see this in the aorta as well. The aorta can become stiff and ultimately lead to regurgitation as well. Again, too much inflammation in the body leads to recruitment of these molecules, which can actually destroy the local tissues. Now, another super important high-yield thing they'd like you to know here is about the diagnostics. When we look at an X-ray, we're going to see vertebral fusion or bamboo spine. So what is that? Well, if you draw your attention over here to the spine X-ray, I want you to appreciate how the vertebrae are kind of attached to each other. This is due to osteophyte and new bone formation. Typically, there'd be a bit of a space in between here, right? Kind of a dark shadow where the disc would be. But in this condition, this chronic inflammatory condition, we actually get the spine that kind of molds together. Again, it gets back to this point of it becoming restrictive. The joint erosion and bone spur formation leads to more restriction. We saw it here in the ribs. Now we're seeing it here in the spine. The idea here is that this kind of looks like a piece of bamboo. Whereas in a piece of bamboo, there appears to be fusion between much smaller segments as you go down the area. Also important to know that you can see erosion and sclerosis of the SI joints, classically on the iliac side of the SI joint. So if you draw your attention down here, you can appreciate that there's not much space here, right? This is kind of a bone-on-bone appearance. There's not much space for cartilage because, again, we're getting the bone formation, the fusion due to the overabundance of inflammatory markers that is destroying the surrounding tissue. Now, key point here that you can see some of these findings on an X-ray or a CT scan potentially, but the main thing that they want you to know is that the MRI is going to be the most sensitive for early disease. Why? Because the MRI is the best imaging option that we have available to us. It's the most detailed. However, not everyone should receive an MRI because of a variety of things, including the cost, the time, etc. But for detecting early disease, for detecting small changes, it is going to be the most sensitive. It is going to pick up on those small, early degenerative changes in the body. Now, again, this is in the family of pathologies that has a strong association with HLA-B27. This does not mean that a patient who has HLA-B27 is for sure going to have this condition, but there is a strong association between the two. Somebody who has this condition is likely to have the HLA-B27 gene as well. Additionally, they'd like you to know that this is associated with increased inflammatory markers. Again, we want this to make sense to us. We won't have to memorize too many things. If we have a process that leads to increased inflammation in the body, which this is, we talked about up here, it makes sense then that we'd have increased inflammatory markers as well. Now, finally, when we talk about the management here, one of the first things you need to recommend is physical therapy. Why? Well, this gets us back to this point where we said this does not improve with rest. It does improve with activity. So doing therapy, being active is actually going to help these patients with their symptoms. There's no real way to cure the patient. There's no way to remove this kind of combination between potentially the genetic predisposition and the environmental factors, but we can manage the symptoms. And if activity improves the symptoms, well, let's continue to be active. Let's continue to do therapy, work out of the gym to help with those symptoms. They also want you to know that you can use non-steroidal anti-inflammatories. Again, pros and cons of this treatment option, but we know that this is an inflammatory condition, so using anti-inflammatories should help with short-term symptom management. Now, you can also consider some other options such as TNF-alpha inhibitors. Again, as with most medication, pros and cons. For patients who have something like inflammatory bowel disease or IBD, you might want to stay away or avoid the use of NSAIDs. These patients might be better to use the TNF-alpha inhibitors. But again, there are cons as well, right? What is a very classic con they like to ask about in board questions for the use of TNF-alpha inhibitors? As in, what do you have to do to a patient? What do you have to check in a patient for prior to prescribing this medication? That's right. You need to screen patients for both tuberculosis and hepatitis B. Why? Because putting this medication on a patient's regimen can actually cause to reactivation of these conditions. A classic one they ask about in the board questions is tuberculosis, but hepatitis would be a possible answer as well. And finally, the last key thing I want you to know from this video is that surgery is rarely indicated. Again, it's really about symptom management for these patients. This is a chronic inflammatory condition. There's no real easy fix for this. It's really about symptom management and using some of the medications we do have to keep their symptoms at bay. There's no real reason to go in and do surgery, which is inevitably going to have a lot of risk and probably not a ton of benefit for the patient. So just a possible question then they might give you on test day could be something fairly simple along the lines of a 29-year-old patient presents to the clinic with a chief complaint of low back pain for approximately 2 months. The patient reports a gradual onset of symptoms and that they tend to be worse with prolonged sitting and improve with walking. The vital signs are stable for this patient, and the patient is found to have elevated inflammatory markers on their lab work. The question could then ask you, which of the following is most likely to confirm this patient's condition? They could give you a variety of different options here, including some serum labs like a rheumatoid factor level. They could talk about gene therapy with the HLA-B27, but the best answer is going to be that you need imaging. You're going to need an X-ray or potentially an MRI if they give you that option, but you need imaging to confirm the diagnosis. You cannot make the diagnosis purely on the fact that they are absent of rheumatoid factor plus symptoms or that they have HLA-B27 plus the symptoms. You need that imaging to actually make that diagnosis of ankylosing spondylitis. So just a quick recap of this video. Again, we're talking about our seronegative or negative for rheumatoid factor spondyloarthritis or spondyloarthropathies. In this video, we talked about ankylosing spondylitis, one of the more high yield ones I like to ask you about. So definitely want to make sure that you feel comfortable with this going into test day. Pathophysiology here. The real summary of it is that we get an overactivation of inflammation in the body, leading to T cell and macrophage recruitment, ultimately leading to joint erosion and bone spur formation. This leads to a lot of the restrictive findings that we're going to see as well. The clinical presentation typically going to be a male in kind of the middle age range, often presents with low back pain, particularly in the sacroiliac joint. And again, key point here, this actually improves with activity and worsens with rest. This is opposite of what we would see of more muscular pains or an acute injury in which it would get worse with activity and improve with rest. Now, when we think about some other extra-articular manifestations, we talked about restrictive lung disease, we talked about the aortic findings as well, but basically there's a bunch of different types of inflammation in the body that can be associated with this condition. It's not just joint inflammation, there's other areas that can be inflamed as well. When we think about the diagnostics here, really important to know this bamboo spine, this kind of clinical finding here on an X-ray. They could give you an MRI as well. But again, the point here is that there's kind of fusion of the joints in the kind of a bamboo type shape, where instead of having a space in between here for the vertebral disc, you can see that the vertebral bodies are kind of connected to each other on the image. Now, when we think about management here, there's no real treatment for this, right? We want to avoid things like surgery because there's no indication for it. There's no real need for it. It's not going to help. But we're really just going to manage these patients' symptoms. This can include things like physical activity or physical therapy. This can include nonsteroidal anti-inflammatories or TNF-alpha inhibitors as well.